Neuroendocrine tumors are a diverse group of tumors that arise from neuroendocrine cells, which are specialized cells with both nerve and endocrine, hormone-producing functions. These tumors can occur anywhere in the body, but are most commonly found in the gastrointestinal, GI tract, pancreas, and lungs. Here's an in-depth look at the types of neuroendocrine tumors. 1. Gastroenteropancreatic neuroendocrine tumors, GEP NETs. These nets develop in the gastrointestinal tract or pancreas. They are further categorized based on their location and whether they produce hormones. Gastric nets, stomach. Type 1, associated with chronic atrophic gastritis and high gastrin levels. Type 2, associated with Zollinger-Ellison syndrome, part of multiple endocrine neoplasia type 1 or MEM-N1. Type 3, sporadic and more aggressive. B. Small intestinal nets, carcinoid tumors, and commonly arise in the ileum and jejunum, can produce serotonin, leading to carcinoid syndrome, flushing, diarrhea, heart valve damage. C. Colorectal nets, typically found in the rectum or colon. Rectal nets are often small and detected during routine screenings. D. Appendiceal nets, often found incidentally during appendectomies, usually slow-growing with a good prognosis. E. Pancreatic nets, PNETs, can be functional, hormone-secreting, or non-functional, non-secreting. Functional PNETs include insulinomas, secrete insulin causing hypoglycemia. Gastrinomas cause Zollinger-Ellison syndrome with excessive stomach acid. Glucagenomas lead to diabetes and a characteristic rash, necrolytic migratory erythema. VIPomas cause watery diarrhea, hypokalemia, and echlorhydria, WDHA syndrome. Somatostatinomas, rare, causing diabetes, gallstones, and steatorrhea. 2. Pulmonary neuroendocrine tumors. These nets arise in the lungs and are categorized based on their aggressiveness. A. Typical carcinoid tumors, low-grade, slow-growing, rarely metastasize. B. Atypical carcinoid tumors, intermediate grade with a higher likelihood of metastasis. C. Large cell neuroendocrine carcinoma, LCNEC, high grade and aggressive. D. Small cell lung cancer, SCLC, highly aggressive with rapid growth and early metastasis, strongly associated with smoking. 3. Medullary thyroid carcinoma, MTC, arises from parafollicular cells, C cells, of the thyroid gland, secretes calcitonin, which can be used as a tumor marker, can be sporadic or hereditary, associated with MEN2 syndrome. 4. Pheochromocytomas and paragangliomas. Pheochromocytomas arise in the adrenal medulla, producing catecholamines, e.g. adrenaline. Paragangliomas occur outside the adrenal glands, often in the head, neck, or abdomen. 5. Merkel cell carcinoma, MCC, a rare and aggressive skin cancer, associated with Merkel cell polyomavirus and UV exposure. 6. Other rare neuroendocrine tumors. Pituitary nets, pituitary adenomas, secrete hormones like prolactin, growth hormone, or ACTH. Parathyroid nets, rare tumors producing parathyroid hormone. Adrenal cortical nets, rare, often functional tumors secreting cortisol or other hormones. Grading and staging of nets. Nets are classified based on 1. Grade G1, 2, G3, determined by mitotic rate and Chi67 proliferation index. 2. Stage, based on the tumor's size, spread, and involvement of lymph nodes or distant organs. Symptoms. Symptoms depend on the tumor's location and hormone secretion. Hormone-related, functional tumors, flushing, diarrhea, hypoglycemia, hyperglycemia. Mass effect, pain, bowel obstruction, or difficulty breathing. Diagnosis, biochemical markers, chromogranin A, serotonin metabolites, calcitonin. Imaging, CT, MRI, PET scans with somatostatin analogs, e.g. gallium-68 dotatate. Biopsy, essential for histological diagnosis. Treatment, surgery, primary treatment for localized tumors. Medical therapy, somatostatin analogs, e.g. octreotide, lanreotide. Targeted therapies, e.g. everolimus, sunitinib for PNETs. Peptide receptor radionuclide therapy, PRRT. Chemotherapy, for high-grade aggressive nets. Symptomatic management, hormone-blocking drugs for functional tumors. Prognosis varies widely depending on the type, grade, and stage. Low-grade nets often have a favorable prognosis, while high-grade tumors are aggressive with a poorer outlook. If you'd like more specific details,